Greetings from the International Vaccine Institute and the RADAAR project. RADAAR, or the Regional AMR Data Analysis for Advocacy, Response and Policy, is a Fleming Fund project. It is one of nearly 70 projects, but which is fully dedicated and only to policy planning and advocacy. As far as policy planning and advocacy goes, the objectives of RADAAR are very simple. We look at barriers and enablers to data sharing, what mechanisms we can set in place for establishing policy dialogues, and how to generate a demand from policymakers for policy-relevant data and analysis. When it comes to AMR, policymakers and politicians in the country are grappling with 5 basic questions. Where are we today? Where do we need to go? How do we get there? What works? And how much it's going to cost? RADAAR, through all its activities, is strengthening the capacities of countries to translate AMR data and evidence into policy pitches, and doing it through an easy to understand format, and it gives the options for policymakers to weigh options.
Since I've been involved in surveillance of resistance, I think we have really made a lot of improvement in the quality of data, of laboratory data, knowledge and interpretation of those data. What is still missing in many countries, some are much more advanced, others further behind, we need to take those data and translate them into action. Action for capacity building and continuous quality improvement so that the quality of the data and the knowledge and the interventions is improving, and translating data into action.
So we need ways of rapidly interpreting the data, local data tools that enable data generators to get the value out of the information and return data that can enable local decision-making, and then aggregating data up at that national and international level.
Data and evidence generation is crucial to underpinning context-specific action, but it does require effective translation into intervention and policy to be of value, and collaboration can be a key role in that translation.
I think as technical people, it's time for us to start to think about beyond just collecting data, which is one of the concerns many of our AU member states have raised. It's not just about collecting data, but how can we then work with member states? How can we translate the data into policies? But beyond policies and beyond national action plans, how can we use our findings to drive funding?
RADAAR has run a number of workshops, data workshops, policy workshops, etc., in which we have conducted many polls. So when it comes to translation of AMR data and evidence to policy, countries have clearly expressed that their capacities for translating AMR data into policy pitches is quite poor. In fact, in one particular poll, nearly 67% of the participants said that the capacities for translating AMR data into policy action is quite weak, and nearly all of them expressed that they would really benefit from capacity strengthening initiatives to help them translate AMR data and evidence into policies.
In terms of communicating with policymakers, these people have an incredibly difficult job. They say, well, I'm being asked to promote AMR as a really important thing, but you need to give me this information, and you need to give me the economic case, or you need to give me this information in order for me to be able to take that forward. So I would say it's less that I communicate with them, and it's more that I take a brief from them in terms of looking at, well, what do we need to do then? What information do we need to provide for you so that you can do your job?
One of the key components of this is ensuring that the local community has the ability to perform the analyses themselves and do the research themselves and to support the data for action.
It's an incredibly important point. And data generation is one thing, but we actually need to see that data being used. And one of the gaps that we see is the ability to actually analyse and the availability of tools to do that, so that policymakers can actually look at this and understand what they're seeing and what they need to do with it.
So we really need to be able to discuss AMR with policy people, but also with local community people. And we need to translate the evidence that we now have into action, change policies, and change what we do.
To support countries in translating AMR data and evidence into effective policy pitches, RADAAR has collaborated with the Evidence-Informed Policymaking Network team of WHO.
So EVIPNet is about promoting the systematic and transparent use of evidence in decision making. Secondly, it's about increasing capacity of member states, of countries, to search for, appraise, synthesize, and communicate, disseminate the finding for uptakes themselves.
We are currently piloting in 4 countries, Bangladesh, Nepal, Uganda, and Malawi, a particular approach and process for strengthening these capacities. Once the pilot is done and based on the lessons from that, we hope to build a scaled up model and take this approach to many more countries. The expected outcomes of such an exercise would be improved capacities for translating AMR data and evidence to policy, improved data sharing, perhaps setting the foundation for setting up knowledge translation platforms in countries, and overall strengthened capacities to analyze and make use of the data that is being generated by various countries. The current AMR advocacy efforts within countries, especially in low and middle income countries, has been quite insufficient. There is yet to develop a groundswell of public and societal support that can encourage policymakers and politicians, but at the same time hold them accountable. Towards this, countries have expressed a need, a demand for a step-by-step guide on how to conduct AMR policy advocacy. Towards this, RADAAR has co-developed, along with global, regional, and national stakeholders, a country guide on how to conduct AMR policy advocacy. The AMR policy advocacy country guide that has been developed by RADAAR is primarily aimed at national and subnational stakeholders who are in a position to be able to influence AMR policies and actions within their own countries. We hope to convert this guide also into a series of workshops and offer this to countries so that they are able to effectively advocate for AMR within their own countries and build a groundswell of support from civil society, the public at large, and a whole of society approach to AMR. However, mobilizing the full engagement of politicians and decision makers in the fight against AMR still remains a challenge.
Part of the ongoing dilemma about AMR is that it's a sort of slow burner or a slow killer, unlike COVID-19. It is not something that appears on the main TV news in any country around the world every night.
So this is a collective action problem. It sort of creeps under the radar of most politicians. It's not something that is spatially or even temporarily sort of fixed in time. It has implications that are somewhat elusive and not very easy to see. And that makes it, for politicians, not a very sort of, it doesn't make it an issue with a lot of votes or an issue that really needs attention right away.
The faceless nature of AMR, making advocacy to policymakers more difficulty, and politicians relate to visible problems that the citizenry can see. They can see when loaves of bread are not in the supermarket. They can see when chicken is not in the supermarket. They can see the number of patients that are sick. They can see a number of patients that are dying from either tuberculosis, malaria, or so. But AMR, unfortunately, has been very faceless.
The biggest problem still facing AMR, not enough people talk about it. Not enough people know that it's a problem. And I think civil society and NGOs can play an enormous role in that regard.
The challenge is to overcome a deficit in mobilizing sufficient numbers and kinds of powerful actors to push forward policy and its implementation. As we've learned in many, many other public health and climate change and other threats to humanity, these movements that really get people to pay attention are created by massive networks, coalitions of influencers. And I think AMR needs to move into that space of mobilizing these kind of actors rather than just relying on, though it is important, the popularization of scientific knowledge.
While surveillance data is important, economic data and analysis is vital for AMR policymaking. It allows policymakers to really weigh options. However, at the same time, we know that AMR is driven mainly by human behavior and action. So the linkage between the technical part, like the surveillance, and the social behavioral dimensions of AMR, there needs to be strong linkages between epi-surveillance and the social behavioral aspects of AMR. However, compared to, say, HIV or climate change, the volume of social science research on AMR is minuscule, and it needs to be seriously ramped up.
There's an increasing amount of social research that is pointing to the fact that the reason that we're using antibiotics isn't just because of somebody trying to make a decision and having all of these influences around them, but actually there's much wider, more infrastructural reasons that we end up using antibiotics. Antibiotics end up propping up our systems. And while we've still got such poor hygiene and really, inadequate health infrastructure in many places, and we've not got the capacity to do really good patient care, antibiotics at the moment are propping that up. We need to be really aware of that before we push messages to just stop using them.
We had a hard time in our analysis to find strong associations between AMU and what we measure as AMR. We do find it is significant, but the other contributing factors are so much more important. Well, we do conclude that abundance of AMR is mainly associated to socioeconomic factors and not so much to antimicrobial uses.
Antibiotic use is important, but what really enables spread to occur efficiently is poor socioeconomic factors. And so they're enablers of contagion or spread. And this, in my view, is very related to the One Health concept, because it's basically things you do on a social and infrastructure point of view will make a lot of difference to how much spread you see happening in people.
Now, I think refreshingly, a very large body of social science research, and that body is moving our understanding beyond simplistic interpretations of knowledge-driven practices to understanding that there are particular configurations of the social, the economic, the political, the historical, in which antibiotic use is actually situated and is driven by. So a broader, multi-leveled understanding is where social science research can take the AMR policy and practice field.
While substantial investments are being made to incentivize the discovery and development of new antimicrobials, no new drugs have entered the market for many decades. The potential role of vaccines in managing and mitigating AMR is promising, yet relatively unexplored. Their role, the use of vaccines to mitigate AMR, must be integrated into national action plans for AMR.
We here at IVI focus primarily on vaccines that protect against infectious diseases that disproportionately affect low and middle income countries. IVI's work on vaccines for AMR priority pathogens includes Group A strep, typhoid, non-typhoidal salmonella, Shigella, tuberculosis, and Staphylococcus aureus.
The role of vaccines straddled both the supply boosting set of available solutions to the AMR problem, but at the same time, of course, because of the power of useful vaccines, it is a very much a demand-reducing intervention too. One certainly has to hope, as a result and consequence of the remarkable speed in which we've found vaccines to be useful for minimizing the life threats of this COVID pandemic to those that have managed to get sufficient vaccines so far. This in itself will stimulate the broader use of vaccines for many things in the future, including more directly to help manage AMR.
Through this brief session, we hope that we were able to give you an appreciation of what the RADAAR project has been doing in the thematic domain of AMR policy planning and advocacy. We would really like to thank all our contributors, collaborators, and partners who have been part of our journey and who have contributed their insights and reflections to make this session useful for all of you. We would also like to acknowledge the very generous funding of the Fleming Fund and their fund management agency, Mott MacDonald, for all the support that they've provided to RADAAR. Thank you.